to you in 5 minutes or so. Thank you.
So,
Yeah, we are okay.
Can you, yeah, Dr.
Hello.
Srinivas and Dr. Khanna, we are here. Dr. Gokul,
Yeah.
Okay.
you're live now.
Are you able to hear us?
Yeah, loud and clear.
Yeah.
So this is a 59-year-old, can I have the slides? 59-year-old gentleman who is a chronic smoker, non-diabetic, hypertensive, and has dyslipidemia. And he's got a positive inducible ischemia in the TMT at an early stage. And he's got chronic stable angina. So he's come here for angiography and revascularization. If you see the coronary angiogram, I can show you, show me the angio. So that's the right coronary artery, which shows a sort of a significant lesion in the long segment lesion. Next, please. Next. And then, next, please. You have an LAD, which is a long lesion again, especially at 2 points before the diagonal and after the diagonal. And this is like a borderline lesion. And then we have a circumflex lesion, which is quite eccentric, only visible on the cranial views. Otherwise, on a caudal view, it looks like a OM is absolutely normal, but there is a tight eccentric lesion there. Now, the syntax score for this patient is 0.22, 22, which is like he is both a good candidate for bypass surgery and also for revascularization. And the syntax 2 score is 29. And so we sort of, he tends to more fit into a PCI arm, and then the plan is to do a PCI. But the main interest to show this case is to actually show you the QFFR and how it correlates very well with the FFR. That's the main interest, and this is very important in our setting in India, because now, because we cannot reuse devices, and to do an FFR actually costs us about 70,000 of rupees. And if you tell the patient, not in a triple vessel disease, but in a single vessel disease, that you do not need an angio, it's a big waste of money for him, because he could have got an angioplasty in maybe the same amount. Now, the QFFR does not require a pressure wire, and it is a very good way to actually sort of quantify these lesions, the physiological importance also. And it's done without pressure wire, and if it's sort of, it's a part of the study which Dr. Srinivas is the primary investigator. And if this sort of succeeds, which it is very promising, the correlation with FFR is very high, as we are going to show you here, then probably this would be the way to go in future, especially in countries like India. So I'll pass on the mic to Dr. Srinivas, who is going to be explaining what we have done.
Thank you, Dr. Khanna. Actually, we requested Khanna to come and perform a good peripheral case, but some issues we had to change, and we decided to do a multi-vessel PCI, which he has explained. Can we, if you see, I think we appreciated that LAD lesion, which looks like a long segment, multiple places. How many of you feel it could be important, and especially at the point of septal, just above the diaphragm, it looks little more, and another point in the caudal views, that's the place. And another, in the caudal view, if you can show the caudal, LAD caudal view, AP caudal, scene minus. If you see there also, it looks like in the caudal place at that point of the bend, that again it looks little more. Can you appreciate that?
Yeah, definitely. There are two places.
Two places. And then OM, if you see here, the views, how it is important, you have to learn from it. It looks like totally normal here, but if you carefully watch after that atrial branch continuing as a LCX continuation, there is a tight lesion in the OM.
Yeah.
And it's also seen better in the elevocranial view. Next. So the minus.
Yeah, there
so what we did basically waiting for you, because first we thought we are actually coming to us. We took a pictures of QFR. That's a lesion.
Right.
You see that? That's
yes.
a tight lesion in the scene, also in the cranial view. What we did meanwhile, we acquired the pictures, and then can show the baseline FFR. We passed the FFR wire. This is the FFR wire in. There's nothing. Baseline FFR came like 0.9. Then is the FFR screen coming to you?
Yeah, we can
okay.
see it.
Then
yeah,
we gave adenosine. We gave adenosine, and the value came 0.80. So like sort of 0.75 to 0.8, we take it borderline depending upon the lesion severity. and clinical scenario we tend to decide, but whatever it is what has come is has come, 0.8. We did QFR, the advantage of QFR, what I was telling in the morning lecture also, even the diagnostic angio pictures we can calculate QFR. Okay, in the diagnostic angio what we calculated, the QFR came like 0.78 or something before. This again we took pictures today with a contrast, and you see, are you able to see the screen now? With the QFR value came 0.82 here.
Yeah,
generally they say the 0.5 difference could be there between FFR and versus QFR, and anything correlates of 0.8 will correlate to 0.85 with QFR further like this. So again, if you see, the another beauty is there is a thing from what area to what area we need to stent. Then the advantage of this modality is you can get it, can you move that pointer? And as our technician Lakshmi is moving it, now you get the value. If you see in the right lesion QFR on the right half of the screen, I don't know whether you're able to make it out, then that keeps changing. The value keeps changing, and that is the tightest point where we get a value of 0.82, 0.81. It keeps changing. As we come back, come to the blue segment, totally normal segment, see it's moving, you get a dynamic. Now there it is 1. So as we go down to red area. So that is a point where there is a significant drop is happening, and that means we need to definitely cover the proximal lesion too. And the other point is the second lesion, there is again a drop further. So idea is you can't get away. Other thoughts what we were having was whether to do it only from the diagonal to below or lesion do it separately. Now there is a drop even before the diagonal. It's imperative that we need to cover even the before the diagonal lesion. So that's how we thought as we cover normal to normal. So then we thought we should do entire lesion length coverage. That's where we are, and then in the process, because we already patient took that thing, we can show the today's live further pictures. So that's a value. It came something like on the diagnostic picture, and this it all correlated. We thought we would decide and do stenting for LAD. Do you agree with those things? 0.8 is a value, but depending upon the long segment disease, especially when you have long lesions, FFR tends to become more positive. That we know from our experience, rather than focal short distal lesions. If the lesion is in the proximal vessel, long segment lesion, it tends to come positive more. So next, with that again we use the same FFR wire, and we just saw it with a balloon whether redilatation is required or not, but it went pretty straight. The lesion length which we calculated came like 45. We took 3 into 48. This is Zain's expedition stent which we placed exactly. It suited. We felt. Then we went ahead. Next. It's important to check the proximal location, the caudal view again. We thought it is fine. Next. Then we went up to, because the distal vessel streamed little less, we gave up to nominal 12 atmospheres there. Next. And this is a stent vis appearance which we get. Then probably there is some under-expanded portion just after the distal portion. Next. You see that there looks like minimal pinching, but flow is okay in diagonal. But just after the septal distally, there seems to be, we took a 3.5 12 balloon. Next. And post-dilated. Series of post-dilatations. Next. Then proximally we were careful not to come out of the stent and dilate. It gave more pressure in the proximal portion. So show the final picture what we have now. We didn't take a picture?
No, we didn't.
Okay. So we'll show you the picture now. That's where we are. And after this our plan is to go to LCX and stent it, and then finally we will do RCA, QFR and FFR. Okay.
So can the QFR be assessed prior to stenting? What would be the QFR if you put a 3048 millimeter stent? Does it tell us?
Prior to?
Post-stenting.
Yeah, post-stenting QFR, can it be estimated?
Yeah, we can do that now. We'll show you that live otherwise again. Okay. The value also FFR we can see as well as same QFR we can see.
Sure.
That's I think.
Can we go to the
cranial
view? The advantage
of little back because it was going into a small branch.
The advantage of using QFFR is that it sort of relies on the volume data, and that is so that the prerequisite is that we need to have a good opacification, so a good injection, and that's why whenever we are doing that, we first gave nitroglycerin, intracoronary nitroglycerin to actually dilate the vessels, and then do a good volume injection. It has to be a good either a hand injection or a pressure injection, and then we take 2 orthogonal views, and then the machine actually calculates the QFFR. The advantage is it gives you a segmental QFFR as well, and so you will know which area is tight and what is the value at each point of time. So this is, it's a very good technique which probably if sort of as it appears, if it validates to that level, it probably may be a good alternative to FFR in most of the situations.
Transfer the images. You see, can I show you the setup, how it is arranged? Now we took the pictures, as Ramesh you asked, we'll do the post-stenting QFR immediately in front of you live.
Sure.
This is a picture, are you able to see the lab as such? Because the screen is arranged here, FFR is here, and right to the right of it is just to QFR calculations of values
can you show
come
that
immediately.
Yeah, can you tell the technician to put the QFR on the big screen, please?
Yeah.
Just show that.
Show the QFR picture as she is calculating, please.
Yeah, this is good.
Yeah. Now the steps you can run through the steps what is happening. Meanwhile, we'll finish up this.
Show this screen.
So this is the pre-QFR we see, it's 0.82.
Now you have to take the post one.
Yeah, post one, wait for that.
The images are getting transferred from the cath lab to that machine,
Okay.
in which it can calculate. It will take just half a minute. Post, Priya, okay.
So Dr. Srinivas, we have 2 minutes for you, and then we'll switch to the other lab, but in 2 minutes I'm sure you'll be able to calculate QFR, that is a test for a Medis employee over there.
So actually, our chief technician Lakshmi herself is doing it.
Oh, good. That's very good. So the system is bought. It has to be bought by each cath lab, and it has to be installed. It is an extra monitor or workstation, right?
Yeah. Yes.
And so you need to have enough knowledge about that workstation as well.
Yeah.
So QFR, I mean, there are a couple of companies that are looking at this very closely, and one is Medis system, the other one is CathWorks, which are both available in Europe. None of them are available in the United States yet. We also know that other systems such as imaging systems are also looking very carefully at how QFR might be the way to go for estimation of physiology in the coronary arteries.
What is it showing now?
So here we can see Lakshmi, the chief tech, is pointing at the proximal LAD or the nearly left main, and you can a distal point will be taken beyond the stent. And even though that sometimes the marker may not go exactly where you want, you just have to move it around. Similar to how we perform a QCA in a QCA lab.
That's okay. Just another minute, I think it will come.
Sure.
She's adjusting the contours again.
Right.
We have to check and just adjust the contours minimally, and then and that's okay, Lakshmi. That's fine. She doesn't budge whatever you tell. Oh, she has to do it right. Okay. Show the same screen for a minute more.
Sure, we're going to stay with you for a minute until we are done with this QFR.
Auto, okay.
While she's doing that, can you also measure the FFR at the same
Yes,
time?
yes.
And adenosine is being given, and so that you can measure the FFR.
1. It's 1, no?
Now we got a value of 1.
1 in.
Do you see it?
Yeah,
You see there? Vessel QFR 1.
yeah. We see that vessel QFR is 1.
Yeah, I think that means it has from 0.8, even if you take it will become 1, it's quite useful and important. 3D, you can do that three-dimensional rotation of a LED picture left, so that you can also appreciate anything. And meanwhile, this FFR we can calculate, but we want to run through once, up, down. That same 3D you can scroll up, down. No, below, the index QFR, just keep moving that red one. Okay. So, now can you see it clear?
Yeah, we can see it.
So,
QFR is 1.
so this is all done in about maximum, maybe because of live transmission, she's under little stress, took a half a minute more, but
Yeah.
otherwise it is done in less than a minute's time. Only time is to transfer images from the lab to that screen machine which calculates it, and then that's it. Then sometimes there is a disease across in the other vessels which I showed in the example in the morning. You can also calculate the value of that. And this as you said, we'll also do FFR. Show that? Did you get this value of FFR here? And then 1. How much this has come? Screen.
That we have to do.
Then we will do this and then compare it and get back to you. If you want to break or go to Calcutta, you can do that. Thank you, Ramesh.
Thank you very much.
Now
That's a very good demonstration.
The plan further is next we will do that OM stenting,
Yeah.
and then check RCA also, FFR and QFR, then decide whether to stent that also. Mostly we might end up stenting that too.
That's
Okay?
excellent demonstration of use of QFR, and I think in the future most of the labs will have this so that we can avoid unnecessary interventional procedures in many of these patients. And I think diagnostic tool is really great. Without a wire, if we can obtain the same physiological significance.
Yeah. Thank you.
Thank
you, Dr.
Thank you.
Khanna.
And
my
if we
colleague
have
Dr.
time, we'll
Gokul.
come back to you, Dr. Khanna and Dr. Srinivasa and Dr. Gokul Reddy. Thank you very much.
Thank you. Thanks, Gokul.